Hello and welcome to This Is Your Brain on Drug Psychiatry podcast. It's your host, the punk rock psychiatrist, Dr. Cody Armstrong, and I'm excited to start on antidepressants today. So, we're going to go through a brief introduction of antidepressants, and then I'm going to go over MIOIs as the first class that we're going to discuss. So, just wanted to give you a brief history of antidepressants, kind of what came before them, what what we have now, etc. And then we're going to go in order of kind of how they were developed. So most of the antidepressants that really were effective as helping with depression came around the 1960s and after. So before the 1950s, they actually used opioids and amphetamines. And I mean, these were kind of some of the only medications that were around at that time. Most of the medications that we have today didn't exist before the 1950s, very few. Opioids and amphetamines have been around since the late 1800s. Aspirin's been around since around that time. There's not a whole lot else that was around. And so, and, and we still do use stimulants sometimes today for depression, usually more as an augmentation. You might add an amphetamine like Adderall or Concerta to someone who's taking an antidepressant if they've got a lot of fatigue and energy. So, and the amphetamines are similar to bupropion, where they increase norepinephrine and dopamine. So I think that makes a lot of sense. Opioids, I think a lot of people are probably like, yeah, we've got a long, horrible history with opioids, and they used to be used for depression as well. So that was before the 1950s. And so as we're entering into the 1950s, um, and remember the DSM that we discussed before, it was going through a variety of changes from the first, second, third, fourth, and then on to the fifth. We didn't necessarily even call the mental health disorders, the same. So if you look at those old books, the names change, and ADHD is kind of one of the most funniest ones for all the name changes that had, and we'll go into that when we get into the ADHD medications. But around in the 1950s, patients were thought of as anxious and neurotic, and depression was like not as prevalent as it came to be after that. And so those that were affluent, so those with money, they were treated with psychoanalysis. Remember how we discussed, Freud kind of came up with psychoanalysis, and that developed into psychodynamic psychotherapy. And Freud was a neurologist, but we didn't have medications to treat mental illness at that time. And therapy was all there was. And as these medications came out, that's kind of where the profession of therapy and psychology developed. They kind of took over a lot of that therapy that was being done by psychiatrists, because prior to that, therapy was all we had, right? I mean, in opioids and amphetamines, right? I mean, other than that, all we had was therapy. And I think there's a lot of psychiatrists, and I'm not one of them, that have, not they feel like the psychologist stole their treatment, and there's kind of a rivalry there. I'm a med guy. I firmly am. I am happy to have the variety of folks that do therapy take that over. In my opinion, I went to medical school for 4 years. I went to psychiatry residency for 4 years, and I got all this medication and medical illness treatment or instruction, and I got very little instruction on therapy. You don't need to go to medical school to do therapy. You don't need to have an awareness of medical illnesses. And I think, a lot of people, they confuse the two, psychology, psychiatry, a lot of patients out there, they confuse the two. They don't seem to really know which is which, who does what. And I think that becomes further confused by you have a lot of psychiatrists that are doing therapy, which I'm fine with that. That's a lot of people's thing that they enjoy doing. It's not what I enjoy doing. Not that I don't do some therapeutic interactions within my medication treatment appointments, but that as the medications came on board in the 1950s and 1960s, as the antipsychotics came out and the antidepressants came out, I guess they realized, hey, you don't have to go to medical school to do therapy. Why, we can just train people straight into that. And I think that's great. And I think we don't have enough therapists and social workers and folks like that out there. And so, like I said, around the 1950s, and you had to have a lot of money, right, to get therapy. It was not cheap because psychoanalysis, like that was people were getting treatment 4 days a week with that. I mean, psychodynamic psychotherapy, where it's more like 1 to 2 times a week, but psychoanalysis is even more intense. I mean, you were talking almost every day, and that was the only type of therapy that existed at that time. And so you had to have a lot of money and a lot of time to be able to do that, or have a family that had a lot of money to send you to that treatment. And at the same time, we had barbiturates. And so, actually, I mean, this may blow a lot of you away, or maybe not, but 10% of Americans were treated with barbiturates in the 1950s. 10%. And I think that's where that statistic comes from is that within a year, 10% of people had taken one. I don't know that that would be chronically took all the time, but were treated with, right? That's a lot. I mean, we rarely use barbiturates at all anymore. They're very dangerous drugs, and they're reserved for specific situations now. And when we get into the anxiety lectures, we'll talk about barbiturates because they were the first treatments for that. And so, also related to barbiturates was a medication called meprobamate, and the brand name of that drug is Milltown, and it came out in 1955. And I don't know if you guys are familiar with it. It actually is still out there. It's not. I don't believe it's been taken off the market, but I don't know anyone who takes it or is prescribed it. It's similar to a barbiturate or a benzodiazepine. It's not the same. It's less potent, less sedating than the barbiturates, and it's actually a prodrug of crisperdal. Now, you guys remember what crisperdal is? That's Soma, the brand name Soma. That's a muscle relaxant, and it's a muscle relaxant that a lot of patients want to take because it's addicting, and doctors tend not to want to give it to them because it can be addicting and harmful and cause tolerance and all those issues. And so meprobamate's actually a prodrug of that. And so, what's a prodrug? That's a drug that will later turn into the other drugs. So meprobamate, after it gets metabolized, or something happens inside the body, it becomes crisperdal or Soma. And so, a lot of you are probably more familiar with Soma. This is a drug that basically becomes that. Okay. And it was the very first blockbuster psychotropic drug in the US. It was huge. And I mean, I'm not speaking by experience because I was born in the 1970s and this is 1955, right? But it it was huge. I've watched videos about it. There are famous celebrities from the time that they advertised it on TV shows, kind of like how they advertised cigarettes back in the day. Milltown was one of those that was also advertised. It was widely taken, and it was marketed towards all sorts of things that we would never consider, giving a medication to, right? For children, it was marketed for tantrums and for stammering or stuttering and for school headaches, in quotes. Um, so kids that didn't want to go to school, I guess, and, threw a tantrum, just, give them a sedative. It was it was actually marketed for pregnancy as like a treatment for the, you know, unpleasant symptoms that people have during pregnancy. And it was marketed for, you know, the menstrual cycle, which, you know, I guess what we would call PMDD or PMS. A lot of people more familiar with that term, but PMDD, uh, premenstrual dysphoric disorder, is the DSM name for that disorder now. And if you've got my slides, or, you know, God willing, YouTube is, you know, the video is cooperating and it's on YouTube. You can see I've got some advertisements here, and it shows, you know, the happy children doing Ring Around the Rosie, and the woman who's, you know, on her period, but like interacting with the men. Um, you know, you guys are familiar with the marketing strategies back in those days, but and this was a huge one, and it's one I think a lot of people have never heard of. And so, uh, and then what came next in the 1960s, benzodiazepines came out. And so they're a much safer version of the barbiturates. It's much harder to overdose on these medications, right? And so, like, we'll get into the mechanisms of all that later, but like these were used for depression, right? And because we're talking about, you know, the history of the treatment of depression, and chlordiazepoxide, or Librium, was marketed as a safer version of barbiturates. And once again, 10% of the population was taking this when it came out, and it was highly advocated as well. And so, um, after we've kind of moved through those medications, the MIOIs and TCAs, so the monoamine oxidase inhibitors and the tricyclic antidepressants, they came out around the same time, and they're still around. And so we're going to go into detail on those. And then they were followed by the SSRIs, selective serotonin reuptake inhibitors, the norepinephrine dopamine reuptake inhibitor, bupropion, is pretty much the only one that's marketed. And then the SARIs, like trazodone or nifazodone, that's the serotonin antagonist and reuptake inhibitor class. And then those all came out, you know, in the 1980s. And so the MAOIs and TCAs, they came out in the 60s and 70s. And then we had the series, the NDRIs, SSRIs, those came out in the 80s. And then you had the SNRIs, so the serotonin norepinephrine reuptake inhibitors, coming out, I think, towards the end of the 90s. And then you had mirtazapine, which is the only one in its class of, um, it interacts in a very interesting way with a variety of different serotonin receptors, and we'll go through that complex interaction of how mirtazapine works. So that came out around the same time as those SNRIs, and then kind of we've basically been sitting with just those for like the last 20-30 years, and now over the last few years we're having some new and exciting medications coming out and on the horizon. And so we'll cover those. You know, we're going to go in order here. And so some of those are the neurosteroids. So that's like the zuranolone, brexanolone for um, postpartum depression. And then you've got the NMDA receptor antagonists. A lot of the theories about glutamate, and there's a lot like ketamine and Spravato, and there's a lot of medications that are coming out that are interacting on the NMDA receptor. There's a medication that has kind of been in the works. It's a sestrine modulator. We'll talk about that. And then the hallucinogens, so like our 5-HT2A agonists like LSD and ecstasy. You know, a lot of talk about those with combined with therapy. We'll talk briefly about that. And then just some other mechanisms, the TrkB agonists. There's some research on some medications that are going to be interacting with that receptor. And then the kappa opiate receptor antagonists, that, you know, you have different opiate receptors and they do different things, and so there's some research on that. And so we'll kind of look through some of those. There's some medications that have come out and been approved in our, you know, new generations category, and then there's ones that are under research, and I will kind of briefly go over those. So those are all the antidepressant classes, right? And so the American Psychiatry Association practice guidelines, what do they recommend? And basically, through all the studies we've done, pretty much we're seeing equal efficacy across the board. SSRIs, SNRIs, bupropion, tricyclics, monoamine oxidase inhibitors, they're kind of comparable in efficacy. Okay, that doesn't mean that from one patient to the next that that's going to be the case, but on the average, they're kind of equal. And so, since the SSRIs, SNRIs, mirtazapine, bupropion are safer, we recommend using those first. And then, if you're having further problems, then you could maybe consider the MAOIs and TCAs. And I'll go through kind of an algorithm. Once we go through all these medications, I will talk about an algorithm of kind of, which to pick first, second, third, fourth, why you would do one versus the other. And I think that'll be really helpful for everyone. So, next, how do these medications work? Okay. So, there's a few different ways. So, with the MAOIs, we're inhibiting the breakdown of monoamine oxidase, right? It inhibits that. So, what does that mean? Well, monoamine oxidase, it I'm gonna touch on this when we get into the MAOI inhibitors. It breaks down various neurotransmitters like serotonin, norepinephrine, and dopamine, and some others. And when you inhibit that breakdown, you have more of those. So we're increasing these neurotransmitters. Okay. And then that's what the MAO inhibitors do. And then the way most of these other medications work is they block the reuptake of those monoamines, right? So you're either you've got a protein sitting in the cell wall, or not cell wall, the cell membrane of a neuron, and its job is to take that serotonin, norepinephrine, dopamine, whatever, and pull it back into the cell that shot it out, right? Because you've got one nerve cell on the left, was kind of think of it as left, and the signal's moving to the right. This is, the presynaptic area, and then you've got the postsynaptic area, which is the receiving neuron on the other side, and then you've got the synaptic cleft, which is the space in between the two neurons. And in between there, you have these neurotransmitters. You've got serotonin, norepinephrine, dopamine. You've got tons of stuff. And the presynaptic nerve is emitting these things, and they're going over to the postsynaptic nerve, and they are interacting with a receptor there, which causes, you know, modulation of the signal of the electricity that's flowing through these nerves, right? And so what these SSRIs, SNRIs, TCAs, et cetera, are doing, they're actually, there's a pump on the presynaptic nerve that sucks those chemicals back into the cell. It's for serotonin, it's the serotonin reuptake pump, or reuptake transmitter. And whenever you block that, right? So that's what the medication does. It blocks that reuptake pump. And so it prevents the pump from transporting that norepinephrine back into the cell, leaving it out in the cleft in between the two neurons so that it can further interact with the postsynaptic neuron, right? And so that's basically how most of these medications are working, through a combination of different types of blockade of these transporters that transport these chemicals back into the cell that released them in the first place. Okay. Um, so, and I think people, they wonder, why do these medications take so long to work, right? Because they take weeks to work. But this blockade of the reuptake, it happens immediately, right? That it's not like that function happens 4 weeks later. It happens the day you took the medication. Hours, it gets absorbed, gets into your brain, and causes this action. And that's why a lot of these side effects will happen. Unfortunately, we don't get the good effects at the beginning, we get the side effects. And so you might get some anxiety and some other adverse effects that happen straight away because you're increasing the amount of serotonin in between those neurons. However, unfortunately, that doesn't give us the good effect of improving people's mood. That takes longer, usually 3 to 6 weeks, and sometimes even longer for full effect. And where we'll also see with having better effect down the line, the side effects, the adverse effects, the effects we don't want to happen tend to improve. And so that is, because it's almost as if the receiving neuron becomes numb and tolerant to there being all this serotonin, and so it just doesn't have that same effect. And we don't completely understand how this whole system operates, but we've studied in animal models, we've studied in petri dishes, etc., and kind of tried to see how all these systems and receptors and proteins and things interact with each other. And we've come up with some hypotheses of how this delayed response of having the decrease in adverse effects and increase in improved mood work. And so when you remember, when you take the medication, you're increasing the serotonin immediately. And so that increase in serotonin actually leads to a downregulation and desensitization of autoreceptors. What does that mean? The autoreceptor is on the presynaptic nerve, the cell that released the serotonin. And we're talking about serotonin. We could apply this to norepinephrine or dopamine as well, if that's if that's the chemical that we're dealing with. But we'll take the example of serotonin. The autoreceptor's job is to sense how much of that chemical is out there. So serotonin's autoreceptor will sense how much serotonin's out there, and if it senses, hey, this is too much, and it's going to react to that. And so what happens is that serotonin that gets released, it doesn't just interact with the nerve downstream. It also interacts with the nerve upstream. It's a very complicated process. So not only is there the pump, the transporter that's on that presynaptic nerve that transports that serotonin back into the cell, there's also these autoreceptors on the presynaptic nerve that sense how much serotonin is out there, and they react to, if there's an increase in serotonin, they change their function. They downregulate, desensitize, right? There's a lot of serotonin out there. They're like, oh, we need to calm down. And because those autoreceptors' jobs are to shut the system off. And so when those autoreceptors get downregulated and desensitized, it leads to more release of serotonin at that axon, which is that presynaptic nerve. And so I know that sounds like really confusing, but it's kind of a balancing act, right? And so you've got this action on the autoreceptor on the presynaptic nerve, it ultimately leads to more release of serotonin. And then you've got the postsynaptic receptor. So there's the receptor on the receiving end of the signal. It gets downregulated and desensitized as well. And that leads to decreased synthesis of those receptors. So the receiving cell makes less receptors. And so it actually changes how many receptors are on the cell membrane. And there's some other stuff that happens, and we're not exactly sure maybe how that happens. There's some neurogenesis process going on here, which is production of growth of these neurons, more connections. So neurogenesis means creating new nerves. So you're creating more connections, maybe more dendrites, more axon, connecting these cells together. There's an increase in synthesis of BDNF, the brain-derived neurotrophic factor. That is like great stuff. Exercise increases it, good diet increases it, and SSRIs increase it. And then you also get an increased synthesis of a variety of other proteins. And we don't even necessarily understand what all these proteins are and what they all do. And it's just a very complicated process. And so usually when I'm talking to patients, I don't go into this level of detail because, I mean, who has time? I usually say, it when you take it, it increases the amount. If I'm giving them an SSRI, it increases the amount of serotonin you have, and that may lead to some side effects that you don't like that happen soon after you've taken the medication. And then over time, your body, your brain, it reacts to having more serotonin around, and it adds receptors, takes them away, changes the amount of serotonin that your cells releasing. And it gets into, after weeks of kind of, because it takes your body time. You've got to suck a protein back into the cell and destroy it, or create a new receptor. And that signal has to get down to the nucleus of the nerve, and it has to go through that process of creating that protein and folding it and going through that whole like cell biology process. And that takes weeks. And all that time, levels of serotonin are going up and down and up and down and kind of trying to find their place. And then after a few weeks, months, we end up with kind of the system that we're going to get. And hopefully that's a good system that helps the patient to feel better and get better. But it might not. It might make things worse. And the only way to find out is to just do it and see what happens. And I know that doesn't sound very encouraging, but we don't know what's going to happen to one patient versus another. If you're not doing well and we've tried everything else, let's give this a shot. If it doesn't work out, it didn't work out. But hopefully it does. All right. And so I mentioned, those the block. So the way these antidepressants work, we talked about a lot about the blocking of the reuptake of the monoamines. We talked about inhibiting the breakdown of the monoamines, and then just one more um, method when we're talking about the monoamines themselves is some medications, particularly some of the newer ones, actually have some effect of agonizing serotonin receptors. And we're going to get into a lot of this in more detail later, but you don't just have one serotonin receptor. There's a 1A, a 1D, a 2A, a 2C, a 3, a 4, a 5, 6, 7. You've got like tons of these serotonin receptors. And when you increase the amount of serotonin by blocking the reuptake transporter, that's serotonin will affect all of those serotonin receptors. It will, some of the receptors are on the presynaptic nerves, some of them are on the postsynaptic nerves. Some nerves have some and some don't have, different parts of the brain, or, the gut and different parts of the body. You might have different types of serotonin receptors, but serotonin, if it's inside that cleft, that space in between the nerve terminals, it will, and if there's a receptor that's one of these different types of serotonin receptor, it will go on there. And so if you're blocking that reuptake pump, you've got more serotonin, and serotonin will hit all the serotonin receptors. But there are medications that pretend to be serotonin, right? And they agonize a particular receptor. And so by agonizing, you're essentially mimicking serotonin, but you don't look exactly like serotonin, because if you did, you'd agonize all serotonin receptors. And so there might be a medication, say, that just agonizes serotonin 5-HT1A, right? Or 1D or 2C, right? It might just affect that one receptor. And so some of the medications, that's their mechanism of action. They pretend to be serotonin, but only this particular type of receptor. And some of them increase serotonin to increase on all the receptors, right? And so, and the thing is, these serotonin receptors, not all of them have to do with mood. Some of them have to do with other things. And when I, when before we get into the tricyclic lecture, because tricyclics are so complicated and they just interact with so many receptors in the brain, and that's one reason why they cause so many side effects and why we don't want to use them that often. um, I'm gonna go through all the different types of receptors that these medications interact with and what each one of those is kind of responsible for. And so at this point, we're just kind of saying, hey, we're increasing serotonin. That's going to interact with all serotonin receptors. And there's some medications that just hit certain serotonin receptors. And I mean, some of those are used for migraine prophylaxis. Some of them are used for nausea, right? It's not all mood, right? And we don't even totally understand like exactly what these do. We just kind of have a good guess. So, and if you're following along in the YouTube video, and if it's by working, or you're looking at the slides, I've got here a diagram that shows kind of where the MAOIs are blocking MAO and where the SSRIs are blocking the norepinephrine reuptake pump or the serotonin reuptake pump, and lithium's in there and showing kind of what it does in a certain cycle in there. And so, you can kind of examine this, and maybe my description will make sense when you kind of see, oh, on the left, that's the nerve that's sending the chemical, and on the right, that's the one receiving it. And there's those different type of receptors. And we're going to get into a lot more detail on this. So if you're confused, just stick with me and we're going to get there. All right. And then that's going to bring us to monoamine oxidase inhibitors. And I'm going to go ahead and make this into a separate lecture because I think that will make it easy. So if you just want to learn about MAOIs and you want to skip over some of this intro stuff, you'll be able to go straight to that episode and hear nothing but MAOIs. And so thank you for, tuning in today. I hope that you understand a little more about how antidepressants work. And I hope you will tune in for subsequent episodes where we go through specific medications.